Successful mitral clip for severe rheumatic mitral regurgitation. Case report. Background of surgery. Transcatheter repair of several mitral regurgitation, MR, using the MitraClip system is now a well-established therapeutic option. Here are the inclusion and exclusion criteria of MitraClip. Patient history. An 85-year-old male with a history of atrial fibrillation, sick sinus syndrome with a pacemaker and chronic kidney disease presents with recurrent hospitalization for heart failure. The patient reports symptoms of SOB, orthopnea, over the past week, suggesting worsening of heart failure. Therefore, a multidisciplinary approach is crucial to assess his condition. Physical examination. Vital signs. The patient's vital signs indicate a low blood pressure, elevated respiratory rate, and a reduced oxygen saturation on room air. Clinical examination. Electrocardiogram. The patient's ECG shows ventricular paced rhythm with atrial fibrillation, AF, due to the permanent pacemaker. Clinical examination. Angiogram. The coronary angiogram reveals a case of single vessel disease, specifically a chronic total occlusion affecting the right coronary artery. Notably, collateral circulation from the left anterior descending artery is observed. This finding indicates a significant blockage in the RCA, with compensatory blood flow provided by collateral vessels originating from the left anterior descending artery. Clinical examination. Echocardiogram. Image A shows TTE at parasternal long axis and image B at apical three-chamber views showing rheumatic mitral valve with moderately thickened leaflets and restricted mobility of the posterior leaflet in both systole and diastole. Image C shows 2D image and image D shows 3DT images showing a wide coaptation gap, 4.1 mm. Further echocardiography assessment. Image A and B shows severe mitral regurgitation demonstrated on transthoracic echocardiographic parasternal long axis and apical three-chamber views, as well as image C and D transosophageal echocardiographic showing intercommissural and left ventricular outflow tract views. Image E shows pulmonary vein systolic flow reversal. Image F shows transmitral mean pressure gradient of 2 mmHg, and image G shows mitral valve area of 2.68 square centimeters by planimetry. Pre-procedure assessment. Conclusion. After being assessed by a cardiac surgeon and following a thorough discussion, this patient was indicated for MitraClip. First, due to patient having severe symptomatic rheumatic mitral regurgitation, resulting in recurrent heart failure admissions and cardiogenic shock. Second, due to the patient's advanced age and underlying health issues, the surgical risk is high, with Euroscore 2 at 14.8% and an STS score for mortality at 20.0%. Third, the absence of significant mitral stenosis, transmitral MPG 2 mmG, and the lack of severe calcification over grasping area. Fourth, despite the presence of a right coronary artery blockage with collateral circulation from the left anterior descending artery, there are no abnormalities in the left ventricular wall motion to explain the restricted posterior leaflets. During procedure. MitraClip. Since there was a significant gap of 4.1 mm between the leaflets, the first grasp was performed carefully with careful attention to grasp both leaflets adequately. Only one clip is used instead of two clips to significantly reduce the MR severity to mild. The change in pulmonary venous flow indicate improved forward flow of blood through MV. Then, a measure of pressure difference across the MV is measured as 3 mmHg, indicating blood is flowing more smoothly, and the blood pressure has notably improved to 126/66, denoting an improved overall cardiac performance. The opening of mitral valve is now 2.0 square centimeters, suggesting a reduced obstruction of blood flow, whereas improved in arterial blood pressure positively impact patients' hemodynamic. During procedure, echocardiography. The cardiac surgeon has successfully implanted single MitraClip centrally. Image A and B transthoracic echocardiographic parasternal long axis and apical 3-chamber views demonstrated reduction in mitral regurgitation to mild after implantation of MitraClip, as well as image C and D transesophageal echocardiographic intercommissural and left ventricular outflow tract views. Image E shows restoration of pulmonary venous flow. Image F shows transmitral mean pressure gradient of 3 mmHg. And lastly, image G shows total mitral valve area of 0. 7th 1.3 equals sign 2.0 square centimeters by planimetry. Here is a 3D animation video of MitraClip procedure.
The blue flow filling the left atrium illustrates severe mitral regurgitation, or MR. The percutaneous mitral repair system consists of catheters and the MitraClip device. The catheter is introduced over a guide wire that has been placed using standard techniques. The dilator is used to gradually advance the guide into the left atrium. The guide wire and dilator are removed. The clip is gradually introduced into the left atrium. The clip is precisely positioned above the leak in the valve. The clip arms are opened in the left atrium for final positioning. Color ultrasound imaging identifies the severe MR illustrated here with blue flow. The clip is advanced into the left ventricle below the valve leaflets. The clip is retracted and closed to hold the leaflets together to reduce MR. If the MR reduction can be further improved, the leaflets are released and the clip re-advanced. Positioning adjustments may be made and the leaflets are grasped again to reduce MR. The double orifice opening allows blood to flow on both sides of the clip. The grasp and MR reduction are assessed before the clip is deployed. The catheters are then removed. Securely attached to both leaflets, the clip moves with the valve, allowing blood to flow through each opening. The mitral valve is repaired without open heart surgery. The MitraClip device is made of metal and covered with a polyester fabric to promote healing.
Post-procedure of MitraClip. Based on New York Heart Association functional classification, the patient's condition had improved from Class IV, where the patient is unable to carry out any physical activity and experienced symptoms even at rest. After intervention, it improved to Class II, where there is only slight limitation of physical activity. Additionally, the procedure results in a long-term outcome as the patient had no further heart failure admissions in 5 years, and the MR remained mild on echocardiography. In conclusion, the presented case demonstrates the intervention for rheumatic MR with thickened and restricted valvular anatomy, emphasizing that this procedure is reserved for specific patients. CVT, in collaboration with physicians and other healthcare professionals, should carefully evaluate and choose the most suitable treatment for each patient to ensure a favorable long-term outcome.